So without further ado, I'd like to introduce Dr. Shilad. So I'm going to embarrass you just for a little bit here and read a little bit about you. So she received her bachelor's degree in biology and history, as well as her medical degree with East Tennessee State University. She's completed her general surgery training at East Tennessee State University, where she also served as chief resident. Dr. Shilad is the only fellowship trained breast surgeon in the Stark County area. She's completed her breast surgery training at the Cleveland Clinic in breast surgical oncology fellowship program sponsored by the Society of Surgical Oncology. So we're so pleased to have you today, Dr. Shilad, and I'll let you take it over.
Great, thank you. So I'm hoping to just do a little bit of overview about breast cancer, but also some of the newer things that we're doing here at Aultman. And so we will start just some background information about breast cancer. So there are quite a few women every year that get breast cancer, as well as men, not as many, but certainly men still get breast cancer as well. We tell women that on average, 1 in 8 women will get diagnosed with breast cancer within their lifetime. And that is independent of any kind of family history. The average age of most women who get breast cancer is, again, 68. So most breast cancers are postmenopausal. That is good. There are still a younger group of women who still get breast cancer as well, though. And so there is quite a few women who do get breast cancer. Again, the average age is 68, but we see most commonly in the 45 to 64 age range. We hear a lot about breast cancer screenings and when should you start getting a mammogram and when should you end getting a mammogram. And there are a lot of different national organizations that are telling you different things. And so it does lead to a lot of confusion. Here at Aultman, we follow the National Comprehensive Cancer Network, the NCCN. And so NCCN recommends starting mammograms at the age of 40. And then annually every year from then onward. They do recommend a clinical breast exam with that. And so that's seeing a physician and doing a mammogram every year. Now, women do ask, well, how long should we continue to do mammograms? NCCN doesn't address that, but American Cancer Society, as well as the American Society of Breast Surgeons, they do usually say that you can continue it until you expect less than 10 years of life expectancy. I always tell my patients the funny story is several years ago, I saw a woman who was 93 and I was like, really? We're doing a screening mammogram on a 93-year-old? What are we doing? Why are we doing this? And so I go in and I talk to her and I was like, well, you know, I see we're doing a screening mammogram this year. Everything looks good. It's like, how much longer are we going to keep doing this? And I explained to her that we usually continue until there's less than 10 years of life expectancy left. And she looks at me and she's like, well, she goes, my mom died when she was 102 and I plan on living until I'm 106. And I said, okay, we'll see you next year. And so it is very independent on how long we continue to do screening mammograms. We, of course, don't want to do screening mammograms when it seems that that finding a screen detected breast cancer would not prolong someone's life. And that's what we're looking for, is we want to find smaller cancers that are easily treatable that will help prolong life. Just a little bit of background information. Again, breast cancer is the leading cancer diagnosis in women within their lifetime, and the average risk is about 12%, or 1 in 8 women. It is the second most common cause of death in women. The most important risk factor in women is increasing age. I tell women that on the whole, their biggest risk factor for getting breast cancer is the fact that they're a woman. In the last several decades, we've seen a decline in the rate of breast cancer deaths, which is attributed to good breast cancer screening and early detection. Now, a little bit of information about the breast. So normal breast ductal cells are over here. So a duct, the way I think of a duct is it's just there to carry milk. And The breast lobe, which is this glandular grape-like area, it's the part that makes milk. And then the duct carries the milk out to the nipple and the areola. And then the third part of the breast tissue is fatty tissue. And fatty tissue is this yellow part. It helps give breast its size and shape. And there's the overlying skin, again, the nipple and the areola in this region. Now, normally, there's normal healthy cells that line the inner part of the duct. What can happen to these cells is that sometimes some of these cells can grow on top of each other, and that's called ductal hyperplasia. Ductal hyperplasia is not something we traditionally worry about. Sometimes it's seen on a mammogram, maybe some calcifications are associated with it, but ductal hyperplasia in itself is not a risk factor for cancer, and it's not something we worry about. Sometimes when these cells, though, they can continue to grow and they can start to look a little atypical or strange in appearance. When women have cells that start to look strange or abnormal, it is a potentially concerning factor. And potentially because we know that women who have atypical ductal cells or atypical lobular cells, they're at a higher risk of developing breast cancer within their lifetime. And so those women, there's different things that we do for high-risk screening to watch them closely. Sometimes those cells continue to grow and they fill up the duct. And at that point, they can fill up the duct, they can be abnormal, and there can be in several ducts in a row. And if that happens, it's something that's called ductal carcinoma in situ. So it's abnormal cells that are filling the duct over a span of several millimeters. This next section is ductal carcinoma in situ with microinvasion, meaning that some of these cells are not respecting the boundaries of the duct and they're trying to invade into the surrounding fatty tissue. And that is, again, different from an invasive ductal cancer. Now, an invasive ductal cancer are these same abnormal cells that have now filled the duct and they are now invading into the surrounding fatty tissue, which is why they are called invasive. So these cells are not respecting the boundaries of the duct and they have the potential to spread. Now, how do we find these areas? One of the best ways and one of our best modalities is a screening mammogram. So a screening mammogram should be done annually if there's no problems. And we do elect those to be accompanied by a clinical breast exam. There are cancers and abnormalities that are found only on a clinical exam. So you can have a mammogram and still have a cancer in there, which is why we want those screening mammograms to be accompanied by a mammogram. Unfortunately, mammograms are not 100%. One of the newer mammogram technologies that we have is called tomosynthesis or 3D mammograms. And we'll look at some pictures of that here in a few minutes. A diagnostic mammogram is when there's a problem or a concern. So whether a patient notices something that, oh, I notice a little lump here, or if their doctor or provider notices something that there's something abnormal there, you can do a diagnostic mammogram. A diagnostic mammogram is extra views. I lovingly call them the extra squeeze views because that's when our mammotechs are, they're trying to pull more breast tissue into the mammogram paddles or they're putting in extra paddles. They're just trying to get better pictures and better idea of what's going on mammographically within the breast tissue. So sometimes that's done for a lump, a skin change, or even some new nipple discharge. Sometimes a diagnostic mammogram is done after an abnormal screening mammogram. Ultrasound imaging is good for helping with diagnosis of an abnormal area. We can do screening ultrasounds, but most women have a lot of breast tissue and it's tough to do a screening ultrasound. Ultrasound is really best for a focused, targeted area. The sonographers can put a probe on a specific area and they can then look around right in that area to see, is there a lump there? Is there a mass? Or is this something that's just best seen on mammogram? Now, mammogram imaging, so when we look here, so the lighter, I guess it'd be darker, the grayer part here on the periphery, that's a lot of the fatty tissue. Now, in this mammogram picture, this whiter, denser part is the glandular breast tissue. So this woman has very dense breasts, and the outer periphery you can see is not as dense. So that's more of the fatty tissue. So mammograms are traditionally done in two views. One is the CC, or the cranial caudal, where that's the picture where they squish your breast top to bottom. And then the MLO is where they squish your breast side to side. Now, breast density is sort of how thick is that breast tissue. And so you can see here on this side, the fatty breast tissue, it's not very dense. There's not a lot of white stuff. And so it would be harder for a small cancer or something like that to hide here. Our next level is scattered density, where there is some denser glandular part. There's heterogeneously dense, where there's increasing density. So it would, so there would be more glandular dense breast tissue in here. And then extremely dense is all of this white glandular dense breast tissue. Now, we know that it is in fact harder to find a breast cancer in women who have extremely dense breast tissue, just because the way the mammography images work, there could be a small cancer in there, and it would be slightly more challenging for the mammographers to be able to see cancers in there. Now, the other part with that is that unfortunately women who have denser breast tissue, they do have a slightly, very small, slightly higher risk of developing breast cancer. And it's something that we want to watch very closely. One of the newer technologies that we have is the 3D mammography or tomosynthesis. Now, if we look in this video, so 3D mammography is great because when they take your mammogram pictures, they squeeze your breast, and it's a little, they take lots of little pictures, and so it goes doo, 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 doo. And so all those little beeps are them taking different mammogram pictures of the breast tissue. And when they do that, they're getting lots of little slices of the breast tissue. So this little video is a comparison of a regular old-fashioned mammogram versus a new 3D mammogram. And when the radiologists look at the new 3D mammogram pictures, you see right in there, let's see if I can pause on it, right there, a spiculated mass that ended up being a cancer. And when you look over here, you can sort of use your imagination and see that there is a slightly denser area there. But here you can definitely see it's spiculated, it's irregular. So this would be a finding that the radiologist would see best on the 3D mammograms. So I'm a huge proponent of 3D mammograms. It's great for women who have dense breast tissue, but it's also really good for women who don't have as dense breast tissue. And so 3D mammography is really great for those reasons. Now, one of the other things that we do like to talk about is high-risk screening. So who needs high-risk screening? Who do we need to watch more closely? Who is at an increased risk of developing a breast cancer? So these are women who carry one of the genes that increases the risk of developing breast cancer significantly, whether that's the BRCA1 or 2, women who have the P10 gene or Cowden syndrome. Li-Fraumeni is another gene mutation that some women have. ATM, CDH1 is another common one, NF1 and PALB2. Now, some women, they know that they carry these genes and there's a family history of it. Other women just have a strong family history of breast cancer. And those women, it's sitting down, looking at their family history. When are women getting breast cancer in their family? Are there men getting breast cancer in their family? And what do we need to do to watch those women more closely? One of the groups of women that I'm finding don't know that they're high risk are the women who have had thoracic radiation between the ages of 10 and 30. So thoracic or mantle radiation is given to the chest and the sternum. And so with that, at that young age, their breast tissue is getting radiated, and it does significantly increase their risk of developing breast cancer. So those are also a group of women that we like to watch closely. A personal history of atypia or LCIS. Now, atypia are those strange cells we talked about earlier, that atypical ductal or atypical lobular hyperplasia. Or LCIS it's an odd misnomer, and we want it to be renamed, but it hasn't been yet. It stands for lobular carcinoma in situ. And even though it has the name carcinoma in it, it is not actually a cancer. But women who have lobular carcinoma in situ, or LCIS, they are at a higher risk of developing breast cancer in either breast. And so those women, the women who have atypia or have lobular carcinoma in situ, they are women who there is a benefit to them having something called chemoprevention, which is a risk reducing therapy that lowers the risk of developing breast cancer, as well as high risk screening. The other group of women is the lifetime risk of developing breast cancer greater than 20%. That is a lot of times based on whether or not they've had babies, how old they were when they had their first child, their BMI, so their weight relationship to their height, and their reproductive history. Now, the other part of that is actually also breast density. So again, women who have these risk factors, having babies older in life or having a higher BMI, as well as denser breast tissue, can potentially fall under the risk of having a lifetime risk of developing breast cancer greater than 20%. And sometimes those women are watched more closely with MRIs. Now, breast MRI imaging we love it, and sometimes it makes us very frustrated because it is much more sensitive than a mammogram. And so again, we like it because it is very sensitive. It detects lots of little things. However, its specificity is much low, so as low as 37%. What that means is that the breast MRI can detect things which are completely normal, but it requires more of a workup. And so I usually tell women that with their first breast MRI, about 1 in 4 women, 25% of women have to go back to the breast center and have another ultrasound and potentially a biopsy, because the MRI is seeing things that were not otherwise seen on their breast tissue. We also know that because it is so sensitive, it does tend to overestimate the burden of disease in known cancers. This potentially has some drawbacks, because if you have a woman who would be a lumpectomy candidate and an MRI shows that this area is larger than initially anticipated, sometimes those women choose a mastectomy instead of a lumpectomy. But the other side of that is it is also very good at identifying other types of cancers, like a lobular cancer. Now, lobular cancers we know are not seen as well on ultrasound or mammogram and are seen much more clearly on a MRI. So in those situations, it is one of those tests that we do like to have an MRI in that situation, because we can see how much of the breast is involved much more clearly. So here off to the side, I have a picture of a breast MRI. And so this is a woman who felt a mass in her breast, and it was biopsied and it came back as being ductal cancer with some lobular features. And we said, well, it's a lobular features. Let's go ahead and check an MRI on her. And so this MRI showed that a majority of her breast was involved. And then when you compare that to her mammogram just showed this area and this area. So for her, she had a lobular cancer, and her mammogram grossly underestimated the amount of disease that she had in that breast. Now, MRI is not for everyone. There are certainly situations where we're all very comfortable doing surgery and women get appropriate treatment with just a mammogram and ultrasound, but there are other situations where an MRI is or it adds a lot of information. Now, what makes a breast cancer unique? This is one of the tricky areas that we see, because there's so many women who have breast cancer now. And with that, women talk, and we all like to say, oh, like this woman had breast cancer and this woman had breast cancer, and we sort of try to get support and camaraderie. But then it's important to realize that most women, their breast cancers are different than their friends. And there's a lot of different factors that go into each woman's breast cancer. So stage is made up of tumor size, whether or not the lymph nodes are involved, as well as tumor characteristics. And those tumor characteristics are whether or not they respond to the natural hormones in the body, so the estrogen receptor and progesterone receptor. And those are both independent factors, as well as something called HER2/neu. Now, HER2 is another marker that's on tumor cells. We know that women who are positive for HER2, they do tend to have slightly more aggressive breast cancers, but there's excellent treatment for women who have HER2 positive tumors. The other factor that helps sort of make everyone's cancer more unique, or it helps differentiate those things, is a test called an oncotype. Now, an oncotype is a gene level assay that's performed on the tumor after it's removed usually, that helps give what we call a recurrence score, the likelihood that this cancer is going to come back. And so I call it a personality test of the tumor. It gives a lot of insight into whether or not it has more aggressive features or less aggressive features. Now, we have lots of different treatment options when it comes to women with breast cancer. So there's lumpectomy, mastectomy, sentinel lymph node biopsy, where we just check one lymph node or a few lymph nodes, axillary lymph node dissection, where we take out several lymph nodes, chemotherapy, endocrine therapy, radiation therapy. Some women only use or only have one of these treatment options. Some women end up getting everything, and everyone's a little bit different. It's a very tailored approach. And so, some women just, again, have a lumpectomy with a sentinel node and radiation. Some women, we do a lumpectomy and they have multiple positive margins, and then we need a mastectomy. And so there's lots of variability in the different treatment options that women have. And we really do try to focus each woman's treatment to be the best for them specifically. Now, as far as surgical updates here at Aultman, I guess I was fortunate that I was able to spend a year at the Cleveland Clinic. And with my year up there, I was able to spend that time with their breast surgical oncologist as well as their plastic surgeons. And I was able to sort of learn all those tricks and things that they're offering up there and bring them down here. And so it was a great experience. And it made me happy to know that I could sort of offer all those things that they offer up at the Cleveland Clinic down here at Aultman. And our women didn't have to go as far. And I was really pleasantly surprised during my time up there that they sort of felt the same way, is that they were seeing a lot of women from this region going up there that now wouldn't have to. So they were glad that they were able to sort of help our women down here, so that way we'd all get a little bit better care and more updated care. Now, mastectomies have changed a lot over the years. So historically, a mastectomy, you're removing, as much of the skin as they could, the muscle. And so that's how things were done historically, all the lymph nodes, even the muscle. Now, I guess probably about 40 years ago, they stopped removing the muscles. They limited the amount of tissue that they had to remove. And so mastectomies now, frequently you can end up preserving the muscle, preserving a majority of the lymph nodes and the skin. So some women choose to be as flat as we can make them. Unfortunately, some women we just can't make as flat as they would like to be. Everyone's body shape is a little bit different. And so again, there's a lot of variability just based on everyone's own factors. Again, some women are very flat, some women have much more lumps, bumps, and wrinkles, and it's sort of the way that everyone is. Now, as far as reconstruction goes, we have different options for that. Historically, when we started doing reconstruction was done below the muscle. And it was first done with an expander. So an expander, which would be like a water balloon, was placed under the muscle. That muscle was slowly stretched out. And then eventually that expander was taken out and a final implant was put in. We still do this, and we try to make it, again, very patient specific, which patients would benefit with having their reconstruction below the muscle. But the other thing that we do is we can now do reconstruction on top of the muscle. And there is a special material called an acellular dermal matrix that the plastic surgeon can use to wrap the implant to help provide a little bit of cushioning between the implant and the skin. And so when they first started doing this, they would always put in an expander beforehand, that same temporary water balloon. But now in certain women, we can put in their final implant at the time of surgery. Now, those plastic surgeons, they want things to be good, and we want everyone to be happy with their reconstruction. So it would not be unusual for a plastic surgeon to do a few little tweaks and adjustments after they do this. So sometimes women do need additional surgeries, but it is nice to be able to put in the final implant at the time of the initial surgery. Dr. Lopez, he's our reconstructive surgeon that we work with a lot. He does a type of reconstruction called a DEEP or a DIEP free flap reconstruction. And so it's something that we do together. And so we can do a mastectomy where we remove the breast tissue and we leave the skin envelope. And then what he does, which is amazing, is he can take the blood vessels that go to the fatty tissue of the belly, and he can remove that fatty tissue and then sew it to the blood vessels behind women's breastbones. And so women like it because they essentially get a tummy tuck. We preserve the muscle, so that's good, but he takes the fatty tissue and he can sew it up. So this is great because then it's your own natural tissue. So if you gain weight, it gains weight with you. If you lose weight, it loses weight with you. And so it is wonderful in that sense. It is a huge operation. So I usually tell women that it takes him roughly 8 to 12 hours to do his part. And we usually work together when we do it. But it's a much longer stay. So most women stay in the hospital between 4 and 5 days afterwards. We do usually watch women in the ICU afterwards, not because we're worried about their heart and lungs, but because we want to make sure that that flap, that tissue that he sewed from the belly, that he sewed into the mastectomy space, is staying good and healthy. And the ICU is one of the best ways to watch that. And so then when women are done, they have a scar going across their belly, and usually sometimes a scar in the breast, sometimes we can do it without a significant scar in the breast as well. And so he can take that tissue from the belly, he can actually take it from the inner thigh, from the buttock region, or even a little bit of muscle flap. And so the plastic surgeons can take muscle flaps from different places to help bring tissue into this area for reconstruction. Now, just as what women can look like, so mastectomies with reconstruction, so these women have autologous tissue, so their own tissue. And so it is good to see just natural looking breasts. Now, one of the newer things that we can offer now is a nipple sparing mastectomy. So when we do a nipple sparing mastectomy is we preserve all of the skin envelope, we scoop out the breast tissue, we remove it, we usually mark where the nipple used to be, and then the plastic surgeon has this space that he then does the reconstruction with. Sometimes we can do the scar in the bottom part of the breast, and other times we put it on the side of the breast. And so this is a reconstructed breast with the scar on the lateral aspect of the breast. And so this would be a nipple sparing mastectomy. Nipple sparing mastectomies are great because when women wake up from surgery, they're usually not missing any skin. And it is great to be able to see, a nipple and an areola. A lot of times women still need tweaks. And again, a little adjustments need to be made. I always tell women it's never as good as the original, but we sure do try. And then this is a picture of a woman who had nipple sparing mastectomies. Her incisions are in the bottom part of the breast, or what we call a hidden scar. And so we're able to scoop out all the breast tissue from there and do her reconstruction. On this side, we had to remove her nipple. And so this would be a areolar sparing mastectomy. And so she still has her mastectomy, but this one we had to remove the nipple. Now, oncoplastics is probably one of the things that's most satisfying. From my standpoint, it's one of the biggest things I learned during fellowship, and then I enjoyed sort of applying those principles to most of the patients that we do any kind of surgery on. So oncoplastics combines the principles of surgical oncology with the techniques of plastic surgery. And so it's for the common goal of the patient. So that way we get a lumpectomy with clear margins and cosmesis. And this is always the struggle with lumpectomies and breast surgery, because you want to you want to take out enough tissue, or you have to take out enough tissue so you get clear margins, but you still want to make sure that the woman's breast looks good at the end. And so that's sort of the tug and war that has traditionally happened when you're struggling with making sure you take out enough tissue so your margins are clear, versus cosmesis, making sure the breast looks good. So historically, when it comes to the way women look after a lumpectomy. And so these are from 1999, a breast and plastic surgeon in actually Paris is one of the pioneers for this. So he's noticing the asymmetry and the different changes. And these are some of the different changes that women can have in their breast after they have a lumpectomy with radiation, because the breast scars afterwards, and sometimes quite significantly. And so what he noticed is that if he uses the techniques of plastic surgery at the time of his lumpectomy, he can rearrange the breast tissue so that way there's not a big stroma, there's less scarring, and then a woman will end up with a much more natural contour of the breast. And then after this side is done, you can reduce or operate on the other side to help its appearance, so that way it's much more symmetrical. Now, the goals of the oncoplastic reductions is we want a complete removal of the area, the cancer with negative margins. We want good to excellent cosmetic results, and we want to take care of this ideally in one surgery. So when we do these in combination with the plastic surgeons, because frequently we're doing a lumpectomy and then they come in and do a reduction at the same time, we are getting much larger margins, which is good. So together we do a lumpectomy, and then the plastic surgeon's goals are to reduce the breast volume, correct the ptosis, and help the breast shape and scarring, and eventually end up with symmetry. And they want to maintain the viability and sensation to the nipple. And so oncoplastic reductions are great when you have women who don't have huge breasts, but they have a lot of tissue that we need to remove. So for this woman, she had 2 areas that were farther apart that we needed to remove. And if I were to take care of this with just a lumpectomy, I can move around breast tissue to some degree, but not as much if we sort of rearrange the entire breast. And so what we did is, so she had, larger breasts, but not huge, and we had to remove quite a bit of tissue. And so we were able to do that with the plastic surgeon. So you remove sort of this upper part of the breast, that's where her cancer and abnormal area was. And then Dr. Lopez, the plastic surgeon, was able to rearrange everything and put things back together. So that way she had a better looking breast. And then this is after radiation. Now, this side right now is much bigger. It's the size that she used to be. And after radiation, usually about 6 months or so, then they do this side to match. Now, we can also do this with women with severe macromastia, even if they have a small cancer. So if you have a woman with macromastia, extremely large breasts, and a small little cancer, if you just remove a small area, then when that area gets radiated, it's not going to do as well. So large-breasted women require larger volumes of radiation to help with the tissue penetration. There's also difficulty with consistency in reproducing the same breast position every time they get radiation. And that can cause inconsistencies with the radiation dosage. And the increased fat content can lead to increased fibrosis. So this woman, even if they have a small breast cancer, we can do a lumpectomy and a reduction on this side. She gets her radiation, and then things are significantly smaller and improved. 6 months after that, we do this side to match. Now on this one, her breast is still a little red. She was very freshly post-op. So that's not unexpected. After everything settled down, she ended up looking great and was very happy to no longer have extremely large breasts, and it was much more manageable for her. Now, fat grafting is one of the newer technologies that we do to help with symmetry and helping how breast can look after either a lumpectomy or a mastectomy. And so what fat grafting is it's essentially liposuction, either of the abdomen or the inner thighs. And so the plastic surgeon gets the fat cells out of that area, and then they spin it down so they just have concentrated fat cells. And then they re-inject those fat cells into the breast spaces, whether that's after a lumpectomy or after a mastectomy. So here's a woman who had a lumpectomy with radiation, and they did fat grafting into this area. And then after, at 2 weeks, 6 weeks, and 7 months. Now, if women get too much fat grafting at the same time, so too many fat cells are injected, it can cause something called fat necrosis. Now, fat necrosis can be very concerning for women because then they can feel that area and they're feeling a lump there. And so most women require multiple episodes of fat grafting, so smaller injections, and then there's less of a chance of that fat necrosis. And now this woman had a mastectomy with initially no reconstruction, and then she had reconstruction down the road. And you can see sort of up top, there's that sort of a hallowing, a dimpling. And so after her fat grafting, they injected more fat into this area, and it helped with the contour, so it's not quite as sunken in there. So lymphaticovenous bypass and axillary reverse mapping is one of the treatment options that we do with lymphedema and for prevention of lymphedema. Now, lymphedema, if we just remove a few lymph nodes, the chance of getting lymphedema is usually about 2 to 4%. If an axillary lymph node dissection is performed, which is where we have to remove all these lymph nodes underneath the armpit, the chance of getting lymphedema can be as high as 15 to 20%. If women get radiation on top of that, sometimes the chances of getting lymphedema can be as high as 40 to 50%. So it's quite significant. And some of the things that are involved in the risk of lymphedema are the number of lymph nodes that are involved, how many of those lymph nodes had cancer cells in them, whether or not they end up needing taxanes, and whether or not they have an increased BMI. So what we do for lymphaticovenous bypass and axillary reverse mapping is we inject a dye into the breast initially. And so this is what we do to identify the lymph nodes that drain the arm. So we inject a dye into the breast. We find our sentinel lymph nodes, those first few lymph nodes that are draining the arm. And then if there's cancer in a significant number of them, and we have to remove these lymph nodes under the armpit, sometimes we do axillary reverse mapping. And so what that is injection of a dye into the arm to identify these channels that are draining the arm. What we can then do in combination with Dr. Lopez, who's our microsurgeon, is we can sew these teeny tiny arm lymphatics that are draining the arm into a small vein. What that does is it helps reestablish the flow from the arm into the venous system, and that's going to be to decrease the risk of getting lymphedema down the road. Now, he does this under a super microscope with teeny tiny suture, and so it is a quite tedious process, but the studies show that this is really good for reducing the rates of lymphedema. And so it's exciting that we're able to offer that here. Savvy Scout is also one of the newer technologies that we're using. So we started using Savvy Scout in 2019. Historically, when women had a non-palpable breast lump or just an abnormal area that had to be removed that we can't feel, and so the way that we found it was women had to come to the breast center and they had a wire that was stuck through their skin into their breast. And so then they have this wire sticking out of their breast in the morning of surgery. So what we transitioned to instead is something called a Savvy Scout. So now women come to the hospital, to the breast center, days before their surgery, and they get this fancy little reflector in their breast. And so this fancy little reflector, so this is the reflector in relation to a dime, and it has these little antennae. So in the time of surgery, I have this probe, or we all have this probe that we use in the operating room to help identify this little reflector. And so it tells us how far away we are from it. And we can use it on the outside of the skin before we start. And we can also use it inside the breast tissue to target the area that this mass is at. And so it's a great way to get women not having to come to the hospital all day and not having this wire sticking out of their breast. And so we've been really happy that we can do the Savvy Scout technology. I always do like to, let me check the time. Okay, briefly, just male breast complaints, because we always want to make sure that that men get treated the exact same way that women get as far as what to do if they notice a breast lump. And so it's the same imaging. So if there's an abnormality, there should be a mammogram and then an ultrasound. And so it should be exactly the same. So excisional biopsy, we do not recommend. It should be the same imaging guided biopsies as a standard of care. So one of the biggest lumps and bumps that men do get in their breast is gynecomastia. And so it can be a rubbery, hard, usually very tender mass behind the nipple. A lot of times men say that their nipple is very sensitive. And so any slightest thing rubbing across it, their shirt, can make it very uncomfortable. There are several causes of it, just aging. And so we see gynecomastia in younger men, but also as men as men get older, as they age. And so younger men, I'm thinking, puberty region is one of the times that we see it, as well as men as they get older and their testosterone levels drop. We see it in men who are overweight, but not necessarily. We also see it in men who use marijuana and drug use. There are also certain kidney diseases and liver diseases that can impact this as well. Male breast cancer is something that happens. They are ductal when they occur. Men don't have lobules, so they can't have lobular cancer. Unfortunately, men usually present at a later stage, just secondary to delay in diagnosis. And so with this, we always want to make sure that if there is a man who has a breast lump, they, again, get appropriate workup, mammogram, ultrasound, because we don't want to cause any form of delay. Men who do get breast cancer should have genetic testing, and that's recommended for all men. And then their first-degree family members are considered high risk, even if their genetic testing is negative. This next one, all men should have a mastectomy. Not so much. Certainly, historically, that's been the case, but certainly if you have a large-breasted man who wants to preserve his breast and is open to the idea of having a lumpectomy with radiation, that is a possibility, but certainly most men end up getting a mastectomy. If they want reconstruction, we can certainly offer that as well. And a sentinel lymph node biopsy is appropriate for axillary staging. And I think we're almost out of time, but I did want to do a few quick things on risk reduction. Women always want to know, what can we do to reduce the risk of getting breast cancer? And so limiting your alcohol consumption, so that would be 3 drinks or less per week. It doesn't make a difference if they're all in the same sitting or if you want to space them out, a half a drink every day. But generally, we want to do 3 drinks per week or less, in that it doesn't make a difference whether it's wine, alcohol, wine, liquor, or beer. So don't smoke, maintain a healthy weight. Eat whole grains, vegetables, fruits, and beans. So try to avoid those ultra processed, very sweet foods that will spike your blood sugar. Limit your red and processed meats. Limit your sugary sweetened drinks. Try to be physically active 30 minutes a day. Breastfeed, and then limit the dose and duration of hormone therapy. Now, certainly we know that some degree of hormone therapy is safe, but just be cognizant and talk to your doctor about how long you want to do that hormone therapy and how strong it's going to be. And again, I think just before we end, briefly on family history. So know your family history. Of course, some people are adopted and they don't know their family history, but be aware of certain breast cancers in the family, or certain cancers. Breast cancers, ovarian cancer, stomach cancer, prostate cancer, and pancreatic cancer are sort of the biggest things that we think about when we think of genetic syndromes associated with breast cancer. And then also be aware that you can get breast cancer genes, and cancer can be on the father's side as well. It's not just the maternal side. So both maternal and paternal sides are important. It can be a lot harder to get a family history from the father's side, but if, the father has 4 sisters and they all have breast cancer and the father had prostate cancer at a young age, that should certainly be raising red flags. Okay, any questions?